Good afternoon, everyone, and thank you for joining us, and thank you for PRI hosting this webinar. I'm going to be discussing this afternoon a little bit about opioid prescribing and protecting your patients and your license. My name is John Morrone, and I am a partner at the law firm of Fryer Levitt. Fryer Levitt is a boutique healthcare firm with 37 attorneys that just practice healthcare law. The presentation that I'm about to provide you is for informational purposes only and does not constitute the practice of law or the establishment of an attorney-client relationship. Any legal questions that you may have should be directed to a competent healthcare attorney. So this afternoon, we're going to be speaking about the issues involving the opioid crisis in America and its impact on practicing physicians and other licensed prescribers. While preparing for this webinar today, we found that as late as this morning, there has been another announcement about funding for opioid combating the opioid crisis. HHS awarded over $1 billion, that's billion with a B, to combat the opioid crisis. The U.S. Department of Health and Human Services has a 5-point opioid strategy that they've announced, and many of those 5 points are incorporated in the recommendations that we make to prescribers. The 5-point strategy to combat the opioid crisis involves better addiction prevention, treatment, and recovery services, better data collection and statistics on who's being affected by the opioid crisis. And that generally means going beyond the typical, oh, it's a street drug user or it's heroin, to really collect the data on all the areas of opioid addiction, and an understanding that opioid addiction is not limited to street drugs, but is really a crisis that is embodied in the drugs that are used both properly and improperly to treat acute and chronic pain. The third point of the HHS strategy is better pain management, and we'll speak a little bit about pain management and the CDC guidelines that have been promulgated, and just general practice guidelines and methods to protect yourself and your practice when prescribing opiates and managing pain. The fourth is better targeting of the use of overdose reversing drugs. And the fifth is better research into the causes of addiction and better outcomes data on the use of alternative pain management therapies, thereby reducing the dependency on opiates as a pain management therapy. So let's take a little bit of a look at the numbers. Probably everyone that is attending this webinar has heard the constant flow of data that comes out basically daily on the network news, coming out of the government, coming out of healthcare organizations and advocacy groups. But essentially, opiates cost the healthcare system $55 billion, both in healthcare and social costs. That's for treatment, as well as lost income, lost work days, etc. 650,000 opioid prescriptions a day are written, and of that, 580 initiate heroin use. It's looked at as one of the key gateway drugs for heroin. So a common scenario is that someone has uh, a work-related injury or an accident, is receives surgery or management in a hospital emergency department or some other primary care delivery system, and is prescribed opiates for acute pain. That individual then becomes addicted, maybe is receiving opiates for a few months, and then their treatment is um, completed with their provider, and now we have an individual that is addicted, no longer has access to legal prescription drugs, and turns to street drugs such as heroin to feed their addiction. Um, some of the more chilling statistics on legitimate opiates is that the U.S. consumes 90% of the world's opiates. A third of all opiate prescriptions are being abused. Um, $20 billion in emergency and inpatient care. 3,900 initiate non-medical use of opiates. And 78 people die in opiate-related overdoses a day, more than automobile accidents. So what are some of the challenges? And this PRI webinar is really focused on the clinicians and their role in this, both the clinician's role and how the clinician has, in many circumstances, been demonized as one of the root causes of the opioid epidemic. So, who should treat pain? What clinical disciplines are appropriate for uh, for managing patients' pain? Primary care physicians, psychiatrists, orthopedic surgeons, pain management specialists, chiropractors, anesthesiologists. Really, there are a broad array of clinical disciplines. Almost every clinical discipline um, may be required to provide opiates as a pain management approach, and virtually all um, clinical disciplines are called from time to time to manage patients' pain. Um, so one of the unfortunate backlashes from this is that many prescribers have, because of being demonized for prescribing opiates, have just withheld treatment and not addressed the issue of both acute and chronic pain, basically kicking the can down the road or leaving the patient to suffer without the appropriate pain management. And clearly that is not a solution to the problem. That's only creating another problem. Patients with acute and chronic pain need to be managed and need to be managed appropriately. For, again, there are a variety of different providers that should be providing pain management. But just to give one example is that patients that receive surgery, where the typical course of treatment is some type of physical therapy post-operatively, if their pain isn't managed, very often those patients cannot follow the prescribed physical therapy regimen, and there we begin down a downward spiral where patients are not, their pain is not treated, they are not attending physical therapy or not participating fully in physical therapy, and they either end up back in the hospital or never fully recover or end up with a host of additional problems. So the answer to pain management is to not just kick the can down the road and not treat patients' pain, but to treat patients' pain um, appropriately and thoughtfully. So although there's enough blame to go around as to what has caused the opioid crisis, and in the current enforcement environment, there is many stakeholders within the supply chain of opiates are being looked at, and in many cases have legal action being brought against them. Um, Allegations have been brought, and there's multi-district litigation against many of the major drug manufacturers um, that produced opiates. Um, some of the allegations that the Department of Justice and many state and local governments in the lawsuits against the big pharma companies is that they inappropriately marketed their product to physicians, having salespeople minimize the risk of addiction, minimize the other risk factors associated um, with with the drugs. But unfortunately, a great deal of attention has been paid, and as I mentioned earlier, demonizing of um, the prescriber as the gatekeeper or realistically the learned intermediary that should be the the one that's truly determining whether it's appropriate for a patient to receive opiates or not. So before we get into the CDC guidelines, I just want to take a moment um, to discuss the, these issues that are being foisted upon um, clinicians. Because we have this opioid epidemic, we've we've run into a situation which occurs from time to time where legislators, non-physicians, non-clinicians are making decisions and making rules that ultimately affect the standard of care, affect um, the practice patterns of clinicians. So one of the one of the areas where opioid prescribing has been affected is with guidelines coming out from a variety of different areas, from professional organizations, from state agencies, whether that be boards of pharmacy, board of medicine, or other um, licensing boards, to organizations or entities like the CDC. So the CDC promulgated guidelines, which by their own measure, the CDC directed these at primary care physicians. The statistics at the time demonstrated that over 50% of uh, opioids were being prescribed by uh, primary care clinicians. So some of the um, some of the highlights of the guidelines, and this is something that everybody that is prescribing opiates should look at and think about, is determining when to initiate or continue opiates for chronic pain, um, selecting the dose and strength of the opiate, um, considering, having a plan and considering the duration of treatment, assessing the risks and addressing the harms of opiate use. So, and this is a very important factor, and this is something that I'm going to take a few moments to speak about, but is really one of the pivotal issues in protecting your patient, your practice, and your livelihood, is evaluating the risk factors for opiate-related harms and ways to mitigate or reduce that. Looking at who the patient is. What is the patient demographic? Are they old? Are they young? Are they in a class that is more subject to addiction? Are we talking, and, and not just addiction, but overdose risks, elderly people that can make um, medication errors and take too much medication or the wrong medications at the wrong time, is to really evaluate, if I give this patient and put this patient on an opiate to manage pain, what are the potential bad outcomes? Um, and in this process, also consider um, what other alternatives there are for managing this patient's pain. Review the PDMP, incredibly important. We here at Friar Levitt, we represent literally hundreds of providers who are um, brought up on charges by professional organizations or professional boards across the country. And you would be surprised to see how many physicians that are charged with inappropriate prescribing, and one of those factors is not um, accessing the PDMP. The use of urine testing to make sure that the patient is actually taking the drugs that are prescribed and not selling them for street drugs and then using heroin. Also, to test for other drugs that may be incompatible or place the patient at a higher risk when they're on an opiate. Um, consider co-prescribing benzodiazepines to lower the need for opiates. Um, and arrange for treatment of for addictive disorders. That's when you do have patients that are being treated for chronic pain who are on long-term opiates, that you direct them to be evaluated by a mental health professional to avoid problems with addiction or to address addiction early on um, in the treatment cycle. So one of the other offshoots of the opioid crisis that I alluded to earlier is that we now have legislators kind of dictating um, what physicians and other prescribers can and cannot do. And in many states across the country, um, a trend has been to implement limitations on opioid prescribing for acute pain. In addition to seminars such as this, I also lecture for the Partnership for Drug-Free America, and I've heard a variety of research that's come out of organizations like that, that addiction often starts within 5 to 7 days of a patient receiving medication. Um, so a number of number of state legislatures have come out with rules that limit a prescriber's ability to write an initial prescription for opiates to either 5 or 7 days. New York has a 7-day limitation. Just across the Hudson in New Jersey, the limit is 5 days. And so, so for initial prescription for acute pain in New York, the prescriber is limited to a 7-day supply. After that 7-day supply, the patient needs to be reevaluated. There are specific exceptions to New York's law, so it doesn't address chronic pain, pain that is related to oncology care or hospice or other end of life or palliative care. As I mentioned earlier, it's critical that you check the prescription monitoring database prior to prescribing or dispensing to a patient controlled substances. The practitioner needs to consult the PMP. And just checking the PMP is not enough. As I very often advise my clients or chat with my clients, is that one of the things that attorneys um, always tell physicians, and I think that it's also said in many medical schools, that if something is not documented, it did not occur. So please make sure that when checking the PMP, you memorialize in the patient's chart that this was done and what was found, so that if there is ever an investigation or anybody questions your prescribing patterns, that you have support for the fact that you followed the guidelines and followed the law in your prescribing practices. So a common question, and it's very difficult. We represent a lot of pain management practices, um, and physicians often say to us that, well, what do I do? And what happens if I have, a patient? Um, well, the 7 day supply issue is you write an initial 7 day supply, and then if the patient still requires pain management, there's a follow up with the patient. And again, documentation for the need for continued opiates for pain management. Really, the essence of um, this limitation on the initial supply is to not provide patients with an unnecessary supply of opioids. Another factor with that is that very often patients receive, a 30-day supply, because it's typically, before the law, the typical prescription is a 1 month supply of whatever the particular drug is. So patients would, have surgery or have a toothache or have some type of dental work done or be seen in an emergency room or whatever the case may be. And the initial prescription was written for 30 days. But in fact, the patient only needed a couple of days worth of pain management. So now you either have a patient that's taking a bunch of opiates unnecessarily, or in many, many cases, um, the drugs are just left in the house, just not used, put in the medicine cabinet. And that creates a whole second set of problems. Now you have individuals that are in the home that may use the medication inappropriately. You have, young people experimenting. They go in the medicine cabinet, and mom or dad or grandma's, you know, remaining, 20 something pills of OxyContin are in the medicine chest, and they're going to experiment with them. We also have issues of accidental overdoses where a a toddler or a young child go to grandma's house and takes this medication inadvertently and overdoses, and we then have a resulting tragedy. Um, so we recommend extreme caution in the issuance of additional prescriptions, um, and providers must document the reason um, for issuing a second prescription. It really cannot be an automatic um, patient needs this, but a true assessment of whether the patient um, needs the medication or just wants the medication. And again, one of the common themes throughout this webinar, and should be a common theme throughout your management of patients, is that what type of pain does the patient have? How severe is it? How can it be managed without opiates? And if I need to use an opiate as one of the tools in managing the patient's pain, how can I minimize the opiate use of the patient? So one of the approaches, or an important approach when prescribing opiates for acute or chronic pain, um, is to have a discussion with the patient, um, and explain to the patient the risks of developing a physical or psychological dependence on the drugs and alternative treatments that may be available. And this is something that many clinicians um, don't spend the time doing, and because very often you don't have the time to do it, to explain to patients and about the drugs that are available for pain management and the alternatives that are available for pain management. It's very often more expedient to just write a prescription than to explain to patients alternatives that may be available, and some alternatives that aren't even medication related, such as cold therapy and physical therapy and things along those lines, that can mitigate the pain, or just even over the counter medication. Very often patients just have a belief that the only thing that's going to alleviate their pain is a narcotic, um, and it's very frequently the patient demanding or patient preference to have a narcotic or an opiate rather than just taking an NSAID, or using ice packs or using cold therapy. Um, Usually at this juncture, I give folks um, a little real world example. Is that I had surgery myself, and I went to one of the best hospitals and best surgeons, and I've been in healthcare for over 30 years. So I kind of know a little bit about the healthcare system, and I had a phenomenal experience in the hospital. But when I walked out of the hospital, or as I was getting ready to leave the hospital, I was given a 30-day supply of OxyContin. Just because of what I do, I didn't take it. I just took regular Tylenol and put ice packs on my incision site, and never took a single opiate. Um, but even though I went to one of the most prestigious institutions, it's a really great physician, a really great institution, and this was relatively, recently, within the last couple of years, is that I was given no guidance at all on the use of opiates or the alternatives of just something as simple as over-the-counter Tylenol and cold therapy. So these are some of the techniques and some of the things to think about when treating patients for acute and chronic pain, is to educate them on the other alternatives. And I think now, because of the opiate crisis and because it's so top of mind in society today, that I believe that patients may be more accepting of these alternative treatments. Um, and so these discussions should really include, what the risks are. That, the risk of becoming addiction, the risk of overdose, um, the risk of driving, or mixing alcohol and the medications that they are. Explain again the alternative therapies, um, kind of approaching pain management using a step therapy like approach, where you start off with uh, the least aggressive or least invasive way of managing the problem, and then progressing to using opiates when they're really needed. Another part of the discussion that you should really consider, whenever you are prescribing opiates to the patients, is the use of, or the availability of, naloxone or Narcan. Um, this slide shows you two of the three methods of delivering Narcan. Um, the picture on the left is Evzio, which is um, contained in an auto injector and provides voice commands to the patients, and kind of the original version of naloxone, which is just a syringe, and a nasal atomizer to deliver Narcan intranasally. Uh, Now, we here at Friar Levitt, we represent, as I mentioned earlier, many hundreds of um, entities in the drug supply chain. We've actually written a number of protocols for pharmacies and physicians for standing orders for Narcan. Um, there are a variety of different policies that are promulgated throughout the country for the use of Narcan, and getting it into the hands of um, the individuals that would be most likely to use them. Now, obviously, first responders, paramedics, EMTs, police officers, paramedics have had um, the the ability and training to use Narcan for decades since the drug originally came out. More recently, um, first responders such as police officers and EMTs have been trained in the use of one of the Narcan or Naloxone products. Um, but it goes beyond that. It's getting it into the hands of the general public. It's educating family members uh, on the use of Narcan. So if a patient is at risk and on an opiate, the getting Narcan into the hands of the family and getting the proper training is it is one of the strategies that's uh, being implemented across the country. Um, so one of the other techniques or one of the other strategies that has been employed, and it has been um, that has been implemented in New York State, is the ability of pharmacies to dispense naloxone on a standing order without a physician's prescription. So we have two areas or two licensees, the prescriber and the pharmacy, that both have the ability um, to provide Narcan to patients and their family. So this is again something to really think about. Now, when you're prescribing an opiate, to prescribe Narcan um, to patients. Now, one of the areas, and this is uh, something that comes out of the unfortunate side of the legal profession, um, is that plaintiff attorneys are constantly looking for new areas to litigate. And as I mentioned, we are a healthcare law firm. Um, we don't sue physicians. We defend physicians and clinicians. Um, but medical malpractice attorneys, I can almost guarantee you that they will sooner or later begin bringing suits where patients die from overdose, where the physician didn't prescribe Narcan, particularly if the prescriber didn't check the PMP and didn't look at the patient's history, and the patient had a history of addictive behavior or suicidal tendencies, and the patient was given opiates but wasn't given a prescription for Narcan. So you should really, in any patient that is potentially at risk for overdose, it is definitely prudent to write a prescription for Narcan. Another alternative, if you're sending, particularly now again in New York because of the requirements to e-prescribe, maybe a good strategy, if you're sending most of your prescriptions to one or two pharmacies, to enter into an agreement with them and provide them with a standing order to dispense naloxone to any of your patients that present with a prescription for opiates. So, as I mentioned, we defend a lot of physicians, so we see, where the government has approached liability or brought physicians up on charges or made other types of allegations. Um, so, what is some of the government's focus? Well, as I mentioned earlier, it's the first thing that the Department of Justice or the Board of Medical Examiners, or in New York, the OPMC, will do is look at documents. the very first thing is they request the medical records. As I said, if it's not recorded, it's not done. So we have seen, you know, what's in the record. Was there documentation um, of a query of the PMP? Was there a discussion with the patient? Were drug screens ordered appropriately? What was the pill count? Was it clinically appropriate, or was there an overutilization? Um, you should always consider utilizing a pain management contract with patients so that there's an understanding upfront as to what the patient is to expect if you're going to be providing long-term pain management. Also, the access to other clinicians and referrals. Um, what was there a clinical strategy for the particular patient's problems? Was the patient referred to an orthopedic surgeon or an interventional pain specialist? Um, was a consult ordered with a mental health professional? These are all things that should be included, that should be done and included in the medical record. Okay. Um, so that these are things that, for want of a better term, legitimate medical practices need to be focused on. And I say legitimate medical practices because I really want to bifurcate the difference between medical practices that are engaging in the true practice of medicine, but may not have thought about or may not have standardized their approach and may not be following CDC guidelines, versus the kind of the pill mills and people and clinicians who know that they're doing something wrong, that they're doing it for financial gain. And that group is often pursued by a more aggressive investigative techniques by the government, where fake patients are sent in with fake complaints, um, sometimes fake X-rays, a variety of different different approaches to see how diligent the clinician is before writing a prescription. Um, they will look at, is they'll bring in fake urine. Um, they'll focus on physicians that are paying cash or demanding cash, as opposed to accepting insurance. So these are types of red flags that they look at, and that's kind of the where the investigative process is going more down the criminal pathway than the professional discipline pathway. So here are just some of the most recent cases that have come out, and this is a really recent one, that this was a physician and his wife that were operating a pill mill. Um, as you can see, he wrote upwards of 50 prescriptions for OxyContin every day. Um, and these folks, although they were elderly, doesn't really matter. They were sentenced to prison terms and civil money forfeitures. So this is really, hopefully nobody on this webinar engages in this type of behavior, but this is the kind of typical bad actor or pill mill physician that you see in the news fairly frequently. As I mentioned earlier, there are a variety of different laws being promulgated across the country at both the federal and state level to help combat the opioid crisis. And we have the Opioid Crisis Response Act of 2018. And this is really directed more at the drug makers and and the availability of opiates. And again, this is just an example of the attention and the financial commitment that the government is making, um, correctly directed or not. It is something that is top of mind and is getting a lot of attention by the government and having money thrown at it. Um, so there are um, enforcement actions, additional pressure coming to bear by the DEA, and frankly limits on the drug supply chain. One of the results now from this act is that many of the drug wholesalers, um, who are also part of the multi-district litigation, um, and sharing some of the blame, uh, are actually limiting, uh, and I think they've reduced almost by a third the amount of opiates that they are distributing to their um, wholesalers and pharmacies. Um, before I get to the REMS issue, I just want to take a step back and just to address what's happening in the drug supply chain and why it is happening. Is that, as most everybody that's in the healthcare system is aware of, is that there is a law called the Controlled Substance Act, which is enforced by the Drug Enforcement Administration, which regulates the ability of, among other things, the ability of prescribers to prescribe opiates or prescribe controlled medications, rather. Part of the Controlled Substance Act places a duty on manufacturers and wholesalers and other participants in the drug supply chain, including pharmacists, to report unusual patterns of distribution, unusual patterns of prescribing. And in the multi-district litigation that's going on right now, that's one of the major focuses, is that people throughout the drug supply chain turn the blind eye to their obligations, to report when either a pharmacy was dispensing an inordinate amount of a controlled substance, when a physician was ordering an inordinate amount of controlled substances, when a drug manufacturer, who's really at the top of the supply chain, who knows what's going out of its door and who it's going to, um, is supposed to report this inordinate distribution of drugs. Clearly, everyone in the supply chain, except really for the physician, had a financial interest in not reporting. Everybody had a financial interest to continue to dispense the medication, to continue to sell opiates. And that is really the nexus of the multi-district litigation against drug manufacturers and other members of the drug supply chain. More breaking news. The FDA recently issued another REMS protocol, which stands for Risk Evaluation and Mitigation Strategy. What REMS basically is, a lot of folks aren't real familiar with it. It's a method that the FDA uses to approve a drug, but to put tighter limits on the way that is dispensed. So in September they issued a new REMS protocol. Now, another one of the most infamous of the REMS protocols is what was called TERF REMS, and TERF stands for transmucosal immediate release fentanyl. These are drugs like Subsys, Actique, and You can see in the regular media that the manufacturer Insys and many of its executives have been indicted for violating a variety of different laws related to turf REMS medication. The turf REMS medication was approved by the FDA for breakthrough cancer pain in patients that were opiate tolerant, and physicians needed to sign a contract and be educated on this, as did the patients. What ended up happening with Insys is that the Insys decided, or Insys allegedly, the executives at Insys weren't satisfied with the market share for their drug within the REMS program. So it is alleged that their sales force marketed to physicians and used tactics that violated anti-kickback laws by providing financial support to physicians in the form of sham speaker agreements to get physicians to write for this very potent opiate off-label. And as of right now, a total of, I believe, 10 executives and 30 prescribers have been criminally indicted in the Insys matter. In one of the most unprecedented things that I have seen in almost 30 years in healthcare was that the FBI, as part of the Insys investigation, the FBI actually put up on their website a notice to patients, a call to arms for patients that if you received subsys, click this link, and that the link led you to a data collection tool, and it asked the patient to actually fill out this form online that included naming the physician and the pharmacy that were involved in prescribing and filling the patient's prescription for Insys, which was something that many of us in the legal system had never seen before. So that's how aggressive the government is in its pursuit of investigations in the opiate world. Another recent law, as you can see, they just are rolling out left and right. Effective July 1, 2018, all manufacturers, distributors, and importers licensed in New York State must report transaction information. All right, this is really in addition to, again, that the duties that all of these stakeholders had under the Controlled Substance Act that weren't followed. New York is just layered on its own law for very aggressive reporting of opiate sales. So we've talked a little bit about all of the scrutiny that folks are under, and how it's going to become even more. And I mentioned a little bit before about my fear of plaintiff lawyers jumping on the bandwagon. So some of the statistics that, as I mentioned earlier, is a third of all opiate prescriptions are being abused. Does that mean that a third of all opiate prescriptions are negligent? Not necessarily, but there may be. Even well-intended clinicians that are truly providing medication for legitimate medical purposes can still end up with a patient that is using the drug negligently. As I mentioned earlier, is selling it for street drugs, taking more of the drug than is prescribed, things along those lines, mixing it with other drugs. So, how is the essence of any malpractice is whether there is a duty, and then is there a breach of that duty. So, medical malpractice is essentially founded on what is the standard of care. So many of these laws and regulations, although they carry various weight, they do begin to establish a standard of care. So, the CDC guidelines, for example, the CDC guidelines don't have the force of law, but they can be used to help establish what a standard of care is. Your professional organizations also can help establish the standard of care. So there is clearly a duty held by the prescriber to the patient. So as I mentioned earlier, is there a duty to inform patients of the availability of Narcan? Probably, or at least a colorable argument. Then we have to deal with causation. Was the negligent prescribing, did that lead to the addiction? Did that lead to the problem? Well, maybe not so much with addiction. It may be very difficult to prove that, or more difficult to prove it. But certainly in situations where we have overdose or accidental death, that I can see plaintiff lawyers being able to sew together a very neat story for a jury. Doctor, are you aware that there was a law that you're only supposed to write for a 7-day supply? And you wrote for a 30-day supply, and the patient overdosed on, the 10th day with the remaining medication that was in that jar. Had you prescribed only a 7-day supply, is it likely that the patient would not have overdosed on the 10th day with the 20 extra pills that were in that bottle? So you can see how easily that can get spun together. And then what are some of the losses, the damages? You have lost income, additional cost of treatment, pain and suffering. The big issue with any malpractice suit that sees a courtroom is that the jury is going to be generally more sympathetic to the victim. So yeah, there is a huge amount of risk that I think is around the corner for not following the guidelines and not following the laws and having a prudent approach to prescribing. So, whenever I speak to physicians on this a lot, it's like it's kind of daunting. That as I said earlier, it's like, well, a lot of physicians have told me, I just stopped. I don't write prescriptions for opiates anymore. That's it. I'm done. I don't want to be in this mess. But many physicians have also told me that it's made it very difficult to treat patients appropriately. So what do we do? So our primary recommendation is that you develop a comprehensive compliance plan for opiate therapy and managing patients. Is the first step is implement written policies and procedures. Particularly in group practices or where we have mid-level providers or other people involved, and is to have a written policy so it's clear how the practice approaches things, how we approach pain. Develop clinical protocols of when do you refer a patient for an evaluation with an interventional pain specialist. What is your pattern for ordering or timeline for ordering urine toxicology, and how long is a patient going to be on opiates before you get a consult for mental health services, or who's checking the PMP and documenting in the chart. In medical practices, and I've done every sort of compliance plan under the sun for physician practices, from HIPAA plans to plans in ambulatory surgery centers to infectious disease plans, is that there needs to be a compliance officer, and it needs to be somebody who carries some weight. It can't just be, some low-level staff person, because we all know what happens with that. Nobody listens to them. So if you're going to not commit to a plan, you're better off not having a plan at all. So you need to take it seriously. Have a compliance officer that's a stakeholder in the practice that has some weight. Provide effective training. Don't just have a policy, but develop training and education for the staff and the physicians and everybody that's involved in the process. And when I say everybody that's involved in the process, it's from the shareholders of the medical practices down to the the receptionists and the clerical people, so they know how to respond for requests for medication and respond to calls from patients and pharmacies on requests for refills of opiates and things along those lines. Enforce the standards. Have some type of internal monitoring and auditing process to make sure that things are being followed, and respond promptly to detect the problems and correct those problems. An example, and I come back to the INSIS issue because it is so it was so sophisticated and so much going on, is that you need to be very cognizant of sales reps and drug reps that are in your practice, and what kind of things they're doing. In fact, there was just a case that came out yesterday calling into question salespeople or representatives of drug or device companies being in a practice and providing certain services directly to patients. So everyone in the practice needs to know that management of opiates is something that is the whole practice's responsibility, and that everybody's in a franchise to deal with this situation and deal with it correctly. And having a comprehensive compliance plan is key. Again, I mentioned this earlier, and I'm not going to belabor it, but exercise good clinical judgment. I think that most physicians know really what needs to be done. And again, we are very understanding, but we are counsel to clients. The practice of medicine is very difficult. It's very time intensive, with prescribing requirements and using electronic health records and reduced reimbursement and all the other things that squeeze providers' time. It's easy to get lost in this and end up in problems. But this is incredibly important that you go through this process, educate the patient, consider ibuprofen, NSAIDs, other drugs before prescribing opiates. Assess the patient's history. Did they doctor shop? Do they have addictive tendencies? Have they been on opiates before? What are the kind of red flags? Query the PMP to detect doctor shopping and pharmacy hopping. Inform the patient of the risks, and prescribe only short-acting opioids with the lowest dose possible for that maximum 7-day, and document. Really key. And one of the other, there are a variety of different strategies to help facilitate this, and it goes back to the compliance plan, is having other members of your care team provide education to patients, develop literature that you can hand patients and explain to them. Information about Narcan, Naloxone, and things like that. Tap into other resources. There are many communities that that offer training to the public in the use of naloxone. Um, so, you know, have those types of documents available. Provide them to the patient, and document in the medical record that you've provided that to the patients. Um, and then, you know, when patients need a renewal after the initial 7-day supply, make sure you're doing the right assessment of the patient. That if you are issuing an additional refill, that the patient genuinely needs it, and that need is documented. And with that, I thank you all for your time this afternoon and for participating in this webinar. And I have a few minutes to answer a couple of questions. I have one question up that says, what if I inherit an opioid habituated patient from another physician and I am concerned about the adverse effect of weaning that patient too aggressively? Can I get in trouble for continuing to prescribe during a taper? And this is a question that comes up a lot with my pain, particularly with my interventional pain practices, where they're getting a patient who's already been on opiates for a long period of time, is probably already addicted. And again, this is, you know, the area where we, you know, where it's tough to manage. It's maintain a standard of care, document everything. I would say in the very beginning, you know, enter into a contract with the patient, explaining what the process is going to be. This is one of the other ugly things that occurs, unfortunately, is that we see a lot of complaints to the Department of Health, OPMC, and things like that from patients who are approaching physicians because they're addicted. And when you try and wean them or try and stop prescribing opiates for them, they get angry and they direct that anger at the clinician. So, you know, my answer is, you know, stay consistent with your standard of care, document and document the process, and that's really the only thing that you can do. Okay, if there's no other questions, again, I thank you all for participating today, and I thank PRI for hosting this webinar, and I hope you folks walk away with some valuable information. And thank you all again.